So our first speaker today is Dr. Wade Kang. Dr. Kang is a vascular surgeon at Bronson Methodist Hospital. He went to medical school at Shanghai Medical College of Fudan University in China. He did his general surgery residency at St. Luke's Hospital in Pennsylvania, and he did his vascular surgery fellowship at Cleveland Clinic. So, Dr. Kang, you have the virtual floor. Welcome, and we look forward to your presentation.
So incision wound healing is a very important aspect of recovery for the bypass patient. And wound healing problem can result in infection, dehiscence, and then result in prolonged hospital stay and increased morbidity for the bypass patient. So BMC2 focus on procedure like EVAR, carotid artery surgery, and bypass surgeries, where wound complications are tracked through the process and improve the patient's outcome across Michigan hospitals. Next slide, please. Okay, so the prevalence of a wound problem actually is pretty common for bypass patient. Within the hospital stay, typically takes anywhere from 4 to 7 days on average. Then their surgical site infection risk while they're in hospital is 4.8%. And for 30-day surgical site infection risk is around 10%. One of the unique incision site is in the groin, which is pretty common for leg bypass patients. And they're very common to have wound problems because there's moisture in there, or there's a movement, and there's a lot of lymphatic disruption cause lymphatic drainage, seroma, and then wound infection. So next slide, please. When there's incision complications, there will be increased chance of reoperation. And if the graft get infected and if we have to remove the graft, there is a major amputation risk. Of course, patient will have readmission, prolonged healing, and hence a higher cost for the healthcare system. And then but then there's no increased mortality on those patients, but just increased morbidity. The next slide, please. The phases of wound healing, there's 4 phases: hemostasis, inflammation, proliferation, and remodeling. Let's go to the next slide, please. So initially, when there's a wound created, the first is bleeding, and then the blood vessels starting to contract, and then cause hemostasis, and then within hours, the fibroblasts come in, macrophages, and then white blood cell come in to clean out the necrotic tissue. That's the second stage. It happens within hours. And then the next stage is proliferative stage. Then the fibroblast starting to multiply, and that stage takes several days, 4 to 7 days. And the granulation tissue starts to grow. Granulation tissue is the tissue full of small capillaries and very highly resistant to infection. That's very important in your wound care healing process. And the last stage takes weeks to months. They call it remodeling. Basically, the scar tissue is starting to soften up, and collagen starting to reorganize, and then the tissue become from a heavy scar tissue become to a normal tissue. Next slide, please. So what's the vascular bypass surgery for the legs? Mostly just to reroute blood vessels around the occluded arteries. There's different kind of bypass. Mostly is the most common is femoral to popliteal bypass. Occasionally we have to do a bypass to further distal to the ankle is a femoral tibial, or sometimes the popliteal artery is a tibial bypass. And a lot of times we have the Harvey's veins, mostly great saphenous vein that will create additional incision wounds. Next slide, please. So patient, typically a vascular surgery patient has a lot of comorbidities like diabetes, morbid obesity. This increase their wound healing risk. And the incisions we made are longitudinal across the leg. For the groin incision, there are different ways to do it. You can do a transverse incision, you can do a longitudinal incision. A lot of times we do this surgery for ischemic patient, and if they have an ulcer, typically they take a longer time to heal. Next slide, please. Common complications we see for the patient with surgical with complications are the surgical site infection and a wound dehiscence, lymph leak. We call seroma. So basically, you have lymphatic going into the wound and then prevent wound healing, and also those lymphatics come out from the bypass graft and coming out to the skin and create a channel from the outside to the inside, and then the graft can get infected. And also the graft infection is another complications. If you have a prosthetic graft and get infected, then you're obligated to take that, remove the graft, and then which can result amputation. Next slide, please. So key patient risk factors, morbid obesity is a very important factor, and have odds ratio of 2.0 if their BMI greater than 30. Diabetes also is very important. When we have elevated A1C level, and they have a significantly increased chance of getting infection. And also smoking, malnutrition, patient being on dialysis, hypertension, and the female gender as well. Next slide, please. So operative techniques during the surgery, it plays an important role. And for the patient with vein harvesting, typically we do a very long incisions, just cut the whole length of the vein. There is a minimally invasive technique that we use to make incision in the groin, and then put the endoscope in there. That will be only two small incisions that has shown to a significant decrease the chance of wound complication. That is most commonly used in cardiac patients for their coronary artery bypass. Because we are using a much long segment of veins, it's not so popular right now for vascular surgeons. So if the surgery takes longer, there's higher chance of wound complication. And if there's more blood loss, patient needed blood transfusion, there's a significant increase in wound complication as well. That's one thing we all know, that if you use iodine prep, you have a higher wound infection risk compared with chloroprep. Okay, and if you have to go back in for any reasons, for bleeding mostly or graft thrombosis, that will increase your chance of wound complication. Next slide, please. Postoperative factors, if you have take patient back for bleeding, or you have end up with an infection, then that's have significantly increased your risk of wound complication. And also poor glucose control, poor nutrition, if there's a lymph leak or hematoma, or delayed mobility or friction in the groin folds. So some patients have a pannus, and then that will keep moisture in the wound, and so we typically ask them to keep padding there, keep it dry. Or I typically tell my patient, do not put underwear in there, because underwear just come right across where the incision wound is, and the underwear rub against the incision wound and can commonly cause complications. And also the transfusion of blood also it's an indicator that the patient have a problems with wound healing. Let's go to the next slide, please. So some of how do we know this matters? And then there's a study in VQI published in 2014 shows transfusion increased surgery time, and iodine prep. That's all cause increased wound complication risk. And there's a meta-analysis published 2024. They look at more than 100 papers, which result in female sex obesity, critical limb-threatening ischemia, kidney disease, on dialysis, transfusion, urgent surgery. Once again, long surgery time, reoperation, that's all increase your chance of wound complication. Next, please. So we talk about that some of the factors are not, we cannot control in the patient's, how ischemic their leg is, how much they weigh. But there are factors that we can potentially control to improve the outcome. That means if we can improve their nutrition, if we can ask them to stop smoking, and control their blood glucose pre-op if we have time. Sometimes for the urgent cases, we don't have time. And for intra-op, if we can make sure that do a chloro prep whenever possible, and then try to use a meticulous surgical technique to decrease blood loss and then decrease the need for blood transfusion, and then use antibiotic prophylaxis and redosing during the case. And for groin closure, there was some study showing that if you use a negative wound vac therapy, can decrease the chance of groin infection, but then at the same time does not decrease your chance of a wound dehiscence. So we used that before, but not as common, because there's a lot of issues with the vac, and the vac is not working, and have trapped moisture inside the wound and actually cause infection. So our practice just right now is just keep the wound dry, and we have pretty good result of that. Post-op is glucose control, early nutrition, and drain removal. If you put the drain in there more than 5 days, actually you have an increased chance of infection. Next slide, please. So what's the role of BMC2 coordinators is we collect the data and track the quality and monitor our surgical site infection risk, and identify those high-risk patients, the patient with diabetes, and so to see if there's anything we can do, and support protocol implementation. So if you found out your hospital have very significant increased risk of surgical site infection, then probably we can looking into it, which is where it's a problem. Like, is everybody using chloroprep? Is antibiotics being redosed throughout the surgery? Or we just simply have a very high risk patient, and then facilitate the quality of improvement initiatives. Next slide, please. So wound healing is a big problem, and influenced by a lot of factors, including patients' comorbidities, operative risk, and post-operative care. But then coordinated quality efforts can significantly reduce the complication risks. There's a lot of information, but I just try to cramp it in. And do you guys have any questions we can discuss?